Hello and welcome to your first endocrine lecture. In this lecture, we will cover diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome. So these are the two extreme disease processes that can occur with hyperglycemia. We will also just kind of take a little review to hypoglycemia and hyperglycemia, or diabetes in general. This lecture is specifically referencing chapter 46 in your MedSurg textbook. If you remember the basics of diabetes, diabetes is characterized by hyperglycemia. So excess glucose in the blood, it raises our glucose levels. We'll have elevated blood glucose results in a finger stick glucose. And it can be caused by a defect in insulin production, a defect in the secretion or the action of insulin, or both. We have type 1 diabetes, which is typically a juvenile onset diabetes, so kids. What would end up happening is you have a child who gets really sick and they can't really determine why until they start to really investigate blood levels and blood sugars. And when they eventually would check a blood sugar on a child, they would notice that they have extremely high blood sugar, and insulin would help, and they would end up being diagnosed with type 1 diabetes. Type 2 diabetes is typically your adult onset, usually diet or lifestyle related. And then we have gestational diabetes, which you guys hopefully talked a little bit about in your OB content. Type 1 diabetes is more often than not an autoimmune disorder. It's characterized by the destruction of insulin-producing beta cells in the pancreas, and it leads to an absolute deficiency of insulin. It's a complex pathophysiology. There's environmental factors, genetic factors, immunological factors. Usually, if there's a genetic predisposition, you could have mom or dad who is a type 1 diabetic, or they might not be have any complications with diabetes and still end up with a child who has type 1 diabetes. Environmental factors can play a pretty critical role, but essentially you have that beta cell destruction. It can be an autoimmune attack. There's that destruction of the pancreatic beta cells, and then a subsequent progressive decline in insulin secretion. So the initial onset of type 1 diabetes, it might not show too many symptoms, but because there is a progressive decline in the insulin secretion, a person would become sicker and sicker until ultimately diagnosed with type 1 diabetes. For type 2 diabetes is a complex metabolic disorder characterized by insulin resistance. There could be insulin deficiency, but essentially hyperglycemia is the result. Could be genetic. There could be genetic predisposition. Maybe parents were type 2 diabetics. A lot of times there's a cultural component, but environmental and lifestyle factors are heavy factors of a person developing type 2 diabetes. The main component is that insulin resistance, fundamental feature of type 2 diabetes. So, we have to take in sugar for energy, and our muscles, our liver, adipose tissue, it all becomes less responsive to the effects of insulin, therefore resulting in a hyperglycemic event or sustained hyperglycemia, and medications would be needed to help reduce glucose production. As for clinical manifestations specific to hyperglycemia, we know the 3 Ps: polyuria, polydipsia, and polyphagia. So you will have that increase in urination, increase in thirst, so they're drinking a lot of fluids, and increase in appetite, so they're just eating a lot. With type 1 diabetes, these patients are really going to be on the thinner side. They'll have some weight loss. There will be fatigue or lack of energy. Frequency of infections as well. Rapid onset, insulin dependent. These patients have to have insulin because the beta cells in the pancreas are not producing it. There's that progressive decline in the production of insulin. There is a familial tendency again, and then it's usually, again, an adolescent, I would say as young as maybe 4, 5, 6 years old. A lot of times will be diagnosed in teens as well. It's rarely, I guess I don't want to say rarely, but it's not typically diagnosed as an adult. The one that's going to be diagnosed as an adult is, again, type 2 diabetes. Your clinical manifestations would be the same. They're still going to have the polyuria, polydipsia, polyphagia. They'll live a more sedentary lifestyle. They aren't active. They aren't engaged in, physical activities. There is still the familial tendency. These will be your 40 to 50-year-olds, maybe 30-year-olds diagnosed as well, but it would typically be probably above age 40, but an average age of 50. You'll see a history of increased or elevated blood pressure, so hypertension, and they'll still have fatigue and decreased energy, and they are more than likely going to be obese. They'll have recurrent infections as well. The clinical management of diabetes is a comprehensive approach. The focus is to control blood glucose levels. We want to prevent complications of diabetes or of the hyperglycemic events, and improving overall health and quality of life. So this involves lifestyle modifications, healthy diet. We have to emphasize with our clients that a balanced diet that's rich in fruit, vegetables, whole grains, lean proteins, and healthy fats. We don't want them drinking a lot of those sugary beverages. And a lot of people will say, oh, if I drink a diet soda, or if I drink the, the Coke Zeros, or the ones that have the zero sugar, it's actually not zero sugar. It's just a different form, and our body still treats it like regular sugar. So even those types of beverages, we're going to have to talk with our patients about it, that it's not, it's not a good replacement. Really, we want to stay away from those sugary beverages. Processed foods are probably the biggest culprit of unhealthy diet. We think, it saves time, it saves money sometimes to get those processed foods, but it's really, it's not ideal. Regular physical activity is huge. Walking, riding a bike, swimming is actually very, very beneficial, especially for your clients who are obese or struggle with physical activity. Maybe they've got knee problems or back problems or whatever. Swimming is actually an excellent activity for them to take place in, because it, you're almost weightless in the water, so movement in the water is a lot easier. But ultimately, weight management is a huge focus. If we can get them, and this is speaking specifically to your type 2 diabetics because they're typically obese, getting weight management, getting them to a healthy weight level is ideal in managing their diabetes. It's very, very important both for type 1 and type 2 diabetics to monitor their glucose levels. A lot of times you'll end up with compliance issues. They forget to check their blood sugar, or they just don't want to. As far as type 1 diabetics, they might have the patches that go on their arm that continuously monitor. That's newer technology that's come out and is excellent. It sends, notifications to their phone or their watch or what have you that, your blood sugar is low or your blood sugar is high, so that they can intervene quickly. We may have, insulin therapy for type 1 diabetics. Sometimes type 2 diabetics will also end up on insulin. It just depends on the severity of their diabetes, their compliance with medications, or if their body just isn't responding well to medications like metformin, they might have to add in some insulin. As far as regular medical care, it is very important that they have ongoing routine visits with their healthcare provider, their primary care physicians. Type 1 diabetics a lot of times will follow endocrinologists. And diabetes educators are huge to have involved in patient care because they can help with diet and lifestyle modifications. They can really just help them understand the process and the importance of managing their diabetes and make it a little bit easier for them to hopefully manage their overall care. Okay, a little bit more on diabetes management. Glycemic index specifically is what we're going to talk about. It's important that we understand what the glycemic index is and how it can be used in managing diabetes, specifically the diet portion. So the glycemic index is a measure that ranks carbohydrate-containing foods based on how they impact blood sugar levels compared to like reference food. So if you take like a slice of white bread, that is essentially pure sugar. So it's not the greatest choice for a person who has diabetes to pick for their food. So if I eat a slice of white bread and I have diabetes, it's going to raise my blood sugar much quicker than if I ate, say, like a lean piece of chicken and some lettuce. So understanding how the glycemic index impacts diet is really important. So because starch will combine with protein and it slows the absorption, it slows that glycemic response. So we have higher glucose levels. Whole fruit is better than fruit juice. If you pick up a bottle of fruit juice from the store, flip it to the back and look at the nutrition label and how much sugar is in that one bottle of juice. It's a heavy amount of sugar. So, you might have a diabetic person who misunderstands that. They grab the bottle of fruit juice thinking, hey, they're making a better choice than soda, but they're actually not. They would be better served just eating an actual orange or eating an apple or eating, that whole fruit because it also has a good fiber content, which who doesn't need more fiber in their diet? Alcohol is significantly high in carbs and it's got a fast absorption rate for carbs. So drinking beer, drinking any of those, any of the alcohols that are higher in sugar. There are some that are a little bit lower, but mostly it's all turned straight to sugar and can elevate blood sugar levels much quicker than other items. Exercise does lower blood sugar. The goal is if they are obese to get them to lower their blood sugar. And, exercise can also help lower the risk of heart disease and hyperglycemic or hypoglycemic events. They are at risk for those. So if you have a type 1 diabetic or a type 2 diabetic and they are exercising excessively, it's really important that they do actually eat a carb-loaded snack before they exercise because the act of exercising in and of itself will lower their blood sugar levels and they could end up hypoglycemic and in trouble in that respect. All right, little refresher on hypoglycemia. So you should have had a lot of this content in blocks 1 and block 2, but I'd just like to cover it just a little bit so we have a bit of a refresher. So hypoglycemia is a condition characterized by abnormally low blood pressures, or blood sugars, blood glucose levels. And it's typically would be below 70 milligrams per deciliter. So a lot of your blood glucose monitors, they'll flag it about 60. Some of them will go, some of them are 70 to 60 or 50 and below. It just kind of depends on what the parameters of the glucose monitor that you are using and what the protocols that the facility chooses to indicate as this is hypoglycemia or not. But typically it's 50 to 70 or below. Causes of hypoglycemia. So we've got too much insulin. Hypoglycemia is often a result of taking too much insulin or other medications that may lower blood glucose levels. Delayed or missed meals. So if you have a type 1 diabetic who doesn't eat, or you have a type 2 diabetic who maybe doesn't eat, delayed or missed meals, purposefully skipping meals, or not eating enough carbohydrates can result in hypoglycemia. So it's it's an education piece for your patients, because if we tell them a low carb diet and they go to the extreme, well, I'm not going to eat any carbs at all, that can result in hypoglycemia. If they have increased physical activity, so they decide that I'm going to get healthy and I want to go walk or run or what have you, if they don't eat before they go and exercise, they can end up with a hypoglycemic episode. Symptoms that we have with hypoglycemia. So there's a whole lot, and these symptoms can mimic a lot of other things. So they can have shakiness or tremors, sweating, diaphoresis, rapid heartbeat, so palpitations, which if they have palpitations, they could think they're having some sort of a cardiac episode. Hunger is definitely an indication. They would have the sensation of wanting to eat. Irritability and mood changes, inability to concentrate, confusion, headache, maybe even some blurred vision. Definitely weakness or fatigue, dizziness, nausea, vomiting, even anxiety or nervousness. And then severe hypoglycemia can actually lead to disorientation. It can lead to seizures, loss of consciousness, and ultimately a coma or death if left untreated. Management for hypoglycemia: if they are awake and alert, we can give them glucose tablets or glucose gel. If they are able to speak and understand, and we know that there's not a swallowing concern, then we can give them the glucose tablets or gel, followed up by maybe some fruit juice or regular soda, not diet soda, but regular soda, because it's got the pure sugar in it. Also, maybe like some hard candies or the glucose candies, things like that. You even could give them a spoonful of like honey or maple syrup, because all things like that are super high in sugar content. I have in the past even taken like a spoonful of sugar and mixed it in water and had the patients drink that if they didn't have anything else available. A lot of your diabetics will carry around the glucose tablets or the glucose gel, because it contains that 15 grams of glucose that can help them kind of raise their blood sugar until they can eat something solid to help raise their blood sugar and sustain their blood sugar. Hypoglycemia unawareness is essentially there's no warning signs until their blood sugar is critically low. It's related to if they've got some autonomic neuropathy or a lack of counter-regulatory hormones. So all of the things that display the symptoms, so the shakiness, the tremors, the diaphoresis, hunger, mood change, confusion, difficulty concentrating, those mechanisms aren't working as well as they should. So patients end up with a critically low blood sugar before they even realize they were low. So these patients, you would have maybe a blood sugar of like 20, 25, or 30, something critically low that they're probably not going to be alert enough to take in anything oral, and they would need the IV dextrose. Okay, further explanation of management of hypoglycemia. So again, the 15 grams of fast-acting concentrated carbohydrate, so that's those glucose tabs or a tube of glucose gel. They would get the entire thing because they need the 15 grams. 4 to 6 ounces of juice or regular soda also. And again, it has to be like the regular soda, not diet soda, because it's the fake sugar in the diet sodas. Our body recognizes it as real sugar, but doesn't utilize it as real sugar. Once we give them that initial dose, we do need to retest their blood sugar. Again, I'm giving an intervention. I need to evaluate if that intervention was effective or not. If it was not effective, then I need to retreat. If I do raise their blood sugar to an acceptable level, we need to give them a snack that's got both protein and carbs within 30 minutes of giving them the glucose tablets or the glucose gel, or else their blood sugar will drop again. So we'll just be right back where we started. If we have emergency management, this would be when a patient can't swallow or is unconscious. We could do sub-Q or IM glucagon. and that's just a quick injection of sugar. We could also initiate an IV and give them 25 to 50 mLs of a 50% dextrose containing solution. So that's our D5, or excuse me, our D50. And I'll show you guys a syringe in class next week when we talk about this. We need to determine the causes. So what was it that caused this patient to become hypoglycemic, and we need to treat for those causes. Moving on to diabetic ketoacidosis. So this is a serious metabolic complication of diabetes characterized by that insulin deficiency, hyperglycemia, ketosis, and metabolic acidosis. There is profound dehydration and electrolyte imbalances. It is crucial that we recognize this promptly and are treating it with IV fluids, insulin therapy, and correcting the electrolyte abnormalities that are present in order to prevent further complications and improve patient outcomes. It is most likely to occur in patients who have a history of type 1 diabetes, and it usually is precipitated by some sort of an infection. But it also can occur in patients with type 2 diabetes, just not as prominent. It results as that severe deficiency of insulin. So maybe a type 1 diabetic, like they ran out of their insulin, or their pump got disconnected, or the battery died, what have you, or they got an infection. But there's that insulin deficiency. Could be increased liposis or ketogenesis. You have elevated levels of FFAs in the bloodstream. The liver doesn't respond as well, and you have synthesis of ketone bodies, which leads to ketoacidosis. Ketone bodies, they accumulate in the bloodstream and contribute, like they're acidic. So ketone, that those levels build up, and acidosis develops. The blood pH lowers, and you have that decrease in bicarbonate levels as well. You have systemic effects of metabolic acidosis. You should have respiratory compensation, so you would see these patients start to hyperventilate, or those Kussmaul respirations, to try and normalize the pH. You can also have osmotic diuresis and dehydration. So the polyuria, polydipsia that we see, they're going to urinate a lot, and they should be drinking, but they might not recognize the amount. So because of that polyuria, they still end up with profound dehydration, excessive loss of fluid through the urine, but also sodium, potassium, and phosphate as well. So we end up needing to treat the electrolyte imbalances, and fluid deficit can lead to hypovolemic shock if we don't replace those fluids quickly. Precipitating factors to DKA. Again, illness. With type 1 diabetics, getting some sort of infection is going to be one of the biggest reasons why they end up with or why they end up in DKA. So illness or infection, inadequate insulin dosage, so maybe their pump shut off or they ran out of insulin. They could have possibly had undiagnosed type 1 diabetes, so they end up sick and in the hospital and subsequently diagnosed with type 1 diabetes. There also could be poor self-management. A lot of times these patients struggle with like social support type things, following up with their primary care providers. It's essentially a chronic disease. It's a chronic medical condition, and you have patients who just aren't as diligent about their medical care as they should be, and as a result end up with a lot of episodes of DKA. It could also be if a patient is relying on, say, family members, or they're in a care home or some sort of facility that they rely on others for their insulin and whatnot. They end up in DKA as a result of neglect. All right, clinical manifestations of DKA. So again, polyuria, polydipsia, polyphagia. You could see rapid weight loss as a result of the loss of body fluids, possibly even breakdown of muscle and fat tissues for energy production because we don't have an adequate amount of insulin. You'll see some nausea and vomiting, general kind of GI symptoms, and that's usually present due to the metabolic acidosis and the accumulation of the ketone bodies in the bloodstream. Abdominal pain, discomfort, it could be diffuse pain or maybe even localized directly in the abdomen. Kussmaul breathing is probably one of the hallmark signs of DKA. So Kussmaul breathing is that compensatory mechanism to reduce the blood acidity by blowing off CO2, so blowing off carbon dioxide. So that deep and rapid breathing pattern, kind of that fruity odor to their breath as well. That fruity odor is because of the elevated ketone bodies, particularly acetone, in the breath that make that sort of fruity odor. Not everybody can smell it. I've worked with nurses who aren't able to smell that odor. But once you do smell it, you understand what that is, and it's really because there's that elevated ketones in the blood, and because our compensatory mechanism is trying to blow off CO2, we also get that that acetone fruity like odor. Altered mental status, DKA can definitely lead to some neurological symptoms. So you can have confusion, lethargy, weakness, even coma, again, in your more severe cases. And if it's not treated, it can lead to death. You've got some cerebral edema, acidosis, electrolyte imbalances, and dehydration affecting that brain function. Tachycardia is a key cardiac sign, so that dehydration, the volume depletion, can lead to tachycardia. So that's our compensatory mechanism. If we have less in the tank, our tank has to pump faster in order to maintain the physiologic demands. There's going to be some hypotension. Again, that's the volume depletion, and we'll have subsequent lower blood pressures. You'll see dry mucous membranes, poor skin turgor, and even a decreased cap refill time. It's essential that we recognize DKA early. Metabolic acidosis, you see a pH of less than 7.3. Their serum bicarb is going to be less than 16. Again, you'll see ketones in the blood and urine, and your electrolytes really could be all over the place, and it's going to depend on the severity of the dehydration. All right, so for the anion gap, the anion gap is a calculated parameter that we use in the presence of electrolyte imbalances. So specifically for DKA, we use it because we know that these patients are in metabolic acidosis. We're looking at the balance of the electrolytes in the blood, and it represents the difference between measured cations, so those positively charged ions, and the measured anions, so the negatively charged anions in the serum. And with metabolic acidosis, we're going to see an elevated anion gap. So your anion gap typically should be less than 10. And with metabolic acidosis that we have present in DKA, your anion gaps will be elevated, 15, 16, 17, up to 20 or higher. And we use the anion gap to gauge our fluid resuscitation and insulin therapy in the treatment of DKA. So as far as treatment for DKA, ABCs, airway, breathing, circulation. So we need to make sure first that their airway is open, it's patent, and we might need to give them some oxygen support as needed. They will be tachypnic and tachycardic, so we want to make sure that they are on some oxygen therapy. We need to get an IV established and begin fluid resuscitation as soon as possible. These patients are going to get probably 2 to 3 liters initially of fluid resuscitation because, one, the profound dehydration, and two, those initial fluids are going to help kind of dilute the blood glucose level. So it's not going to, shove the insulin back into the cells where we need it, but it is going to help kind of dilute the insulin, or the glucose present. So it will just kind of passively lower their blood sugar. We're going to be initiating a regular IV insulin drip. So usually your parameters are going to start at about 0.1 units per kilo per hour. So there will be some calculation done there, but usually your pharmacy will help you out. They'll get a 10-unit bolus or loading dose of insulin, so they'll get that IV. And then the infusion will start. And then kind of the same way we talked about heparin titrations, you're going to titrate that insulin drip based off of hourly blood glucose levels. It is very, very important that we check their electrolyte levels, specifically their potassium levels, prior to initiating the insulin drip. If they are hypokalemic and we start insulin without correcting for that hypokalemia, we could cause a detrimental outcome. A lot of times though, or I guess I should say more often than not, these patients are going to be hyperkalemic. So having to replace their potassium is not going to be needed, but we still must always check their potassium level prior to initiating insulin therapy. And that's just because potassium is like that annoying little brother, and they're going to follow the insulin wherever it goes. So if we are maybe normal low potassium level and we give that insulin, the insulin is obviously going to drive the glucose back into the cells, and the insulin's going into the cells, and the potassium is going to follow. That can result in hypoglycemia. We need to be monitoring their blood glucose levels, and this will be done hourly. So we'll get those kind of baseline levels, and then we will check their blood sugar one more time right before starting the insulin drip, and then hourly blood sugar checks, and we'll titrate the insulin drip as needed. They're going to get a lot of fluid replacement, so it's very important that we do ongoing lung assessments. We want to make sure that we're not sending them into fluid overload. And then ultimately the goal is to reverse the acidosis. So we'll be checking their ABG results and looking for that closed anion gap. So we would consider the anion gap closed once the gap was below 10 to 12. It really depends on the facility's parameters, but usually it's below 10. Okay, here's some general diabetic ketoacidosis guidelines. So as far as how we would do initial care, what the goals of treatments are, don't focus too heavily on this. It's just kind of an overview. It's a good indication of how kind of the flow works. So we have our diagnostic criteria. So your blood glucose level is going to be at minimum 250. A lot of times it's maybe well into the 3, 4, even 500s. I've seen blood sugars in DKA as high as 600, 700. Your arterial pH is going to be below 7.3, and your bicarb will be below 18. Anion gap is greater than 10. You will have ketonuria and ketonemia, so elevated ketones in the urine and in the blood. And those are, that's where our acidosis come from. We've got hyperglycemia, which then triggers an osmotic diuresis. So the profound dehydration, volume depletion, free water depletion. Goals of treatment. Number 1, replace that fluid volume. Number 2, get the insulin going. If the only thing you were able to do right off the bat is to give insulin, that is the only thing that is going to correct the metabolic acidosis. We can give them tons and tons of fluids, but if we only gave them fluid, they would still be in metabolic acidosis. We can give them sodium bicarbonate. That is going to help the metabolic acidosis, but it's not going to correct the reason as to why they are in metabolic acidosis. We have to give them the insulin. We definitely are going to be looking at their electrolyte deficits and replacing as needed. and then figure out why they were in DKA in the first place. So treating that underlying cause. Once the DKA has resolved, so once their anion gap is closed, we need to begin sub-Q insulin prior to stopping that insulin drip. One of the most critical points in switching them from the IV insulin to the sub-Q is that we can end up with hypoglycemia. So once we do switch them, or once we're getting ready to switch them from the IV insulin to the sub-Q insulin, we need to start a dextrose-containing solution. So we'll do maybe a D5 half normal saline or a D5 water, something like that, to make sure they get a little bit of sugar in their IV solution to prevent them from going hypoglycemic. We're going to be monitoring frequent labs. They'll be on cardiac EKG or continuous EKG monitoring. We're doing strict I's and O's, ensuring that they have adequate IV access. A lot of times these patients will have at least 2 access points, because once we initiate that insulin drip, I really don't want anything else going through that insulin line. So if I'm doing still bolusing them fluids, I would want the fluid bolus going through a separate access point. Ongoing labs, ongoing EKGs, all those things just to help support care. Most of the time, these patients are going to be in the ICU just because of the acuity of care that they require and those hourly blood sugar checks. It's just a lot for them to be, or for a med-surg nurse who's got 6 other patients. So typically these patients are going to be ICU level care. As for the initiation of IV insulin, similar protocol to what we saw with our heparin infusions. So the infusion rate, or the infusion starting rate, is based off of the serum glucose level. So when this patient first comes into the ER, we're going to do a blood sugar check. It's probably going to read high, and we're going to draw a serum glucose level that will give us the actual number. As for initiating the protocol, it's usually going to start at that either 0.1 unit per kilo, or 0.1 unit per kilo per hour, or half a unit per kilo per hour, whatever that protocol is. And then we would titrate hourly based off of the point of care glucose level. So the infusion starts off of a serum glucose. We titrate it based off of a capillary glucose. So you can just look at this protocol and, say my repeat point of care blood glucose is 275. Whatever my initiation rate was, my starting rate was, say I started at 8 units an hour, I would go up by 2 units, and they would then be at 10 units per hour. If they spike and their blood sugar goes above 400, I'm going to give them another bolus dose of 10 units of regular insulin, and then increase the infusion rate by 2 units per hour. And then I'm going to call the provider, because clearly what we're doing up till now has not been effective enough in treating this patient. So they might want some new orders initiated. Here is kind of a flow chart in how the management of DKA would work. It's very detailed. Again, I don't want you to panic over, looking at this chart. I provide it just so it kind of shows the flow of treatment and when we would switch from IV insulin to subcutaneous insulin, if they're tolerating oral feeds or if they're not. And then all the way to discharge. So you can just take some time maybe to look over this, but it's very detailed, so I don't want you to be too overwhelmed with information. All right, hyperglycemic hyperosmolar syndrome. Used to be known as hyperglycemic hyperosmolar non-ketonic state, so HHNS. But now it's just hyperglycemic hyperosmolar syndrome, so HHS. So this is a severe, life-threatening complication of type 2 diabetes. It most commonly occurs with type 2 diabetes. It's characterized by profound hyperglycemia, marked dehydration, and hyperosmolarity. there is no ketosis. There's no metabolic ketoacidosis. You still have the same, insulin deficiency, osmotic diuresis, dehydration. It's results from that insulin deficiency or resistance to insulin, and that severe hyperglycemia results. But you just do not have the metabolic ketoacidosis present. But it's a life-threatening condition. These patients need large amounts of fluid and insulin therapy. Precipitating factors typically will be some sort of an infection in a type 2 diabetic. So they get UTIs, they get a sepsis infection or a pneumonia, some sort of acute illness that triggers an increased resistance to insulin or some sort of increased physiologic demand, and they end up in HHS. It also can happen with newly diagnosed type 2 diabetics. So they maybe were recently diagnosed and are learning how to manage it, and then they maybe get sick and they end up with HHS. They will have an impaired thirst sensation or an inability to replace fluid. So those are all kind of things to look out for. HHS has a high mortality rate primarily because of the severity of the metabolic derangement. So those who are older, they have less compensatory mechanisms. They maybe got other underlying medical conditions. Those are all factors that increase or that lead to that higher mortality rate. There's a delayed presentation. So DKA often shows those dramatic symptoms like nausea, vomiting, abdominal pain. So you have some of those just like trigger symptoms that would indicate, they're getting sick. HHS has more subtle initial symptoms. So they'll often delay seeking medical attention. And by the time they do seek medical attention, the blood glucose levels are so elevated, the condition is so severe, there's that delay in diagnosis and treatment, so you have that higher mortality rate. Early recognition is key, but again, sometimes they'll delay seeking care. For the most part, our nursing management for DKA and HHS are the same. We play that vital role in the care of our patients who have either DKA or HHS. We know that these are life-threatening conditions. We know we need to act quickly and provide that thorough care. So assessment and monitoring, thorough assessment, where ongoing vital signs, heart rate, blood pressure, respiratory rate. Neurologic status is going to be probably like initially a Q15-minute evaluation or eventually, maybe every hour, every couple hours. But we're looking at their level of consciousness, their orientation, looking for any changes in their mental status. Signs of further dehydration, further volume depletion, is there skin tenting? Are their mucous membranes dry? Fluid resuscitation in both DKA and HHS is priority. And I am talking aggressive fluid resuscitation. The most amount of fluids that you will give in your nursing career probably will be to these patients with DKA and HHS. They're going to get probably 2 to 3 liter bolus initially just to correct that profound dehydration. We're then going to be monitoring their fluid balance closely after that to ensure what is going in is also coming out, so they'll have strict I's and O's. Electrolyte management, we're going to draw those baseline electrolyte levels, making sure that their potassium is at acceptable level so that we can give them, initiate the insulin therapy. And then our primary priority or our first priority, once we've made sure electrolytes are okay and we've initiated that fluid resuscitation, is getting that insulin therapy started. Insulin is going to be the only therapy that actually corrects the metabolic acidosis in a person with DKA. Insulin therapy is still the primary intervention in HHS because they've got that just severe hyperglycemia. We'll follow the insulin protocols as needed. And once they meet parameters to then switch over to sub-Q insulin, we're going to make sure that we're starting a dextrose-containing solution to prevent hypoglycemia. Follow-up care would mean that they have appointments with their primary care provider. If they need to see an endocrinologist, maybe a dietitian, anything like that to help promote ongoing health and minimize the chance of getting one of these events again. Here is your protocol specific to HHS. So if we have an acceptable potassium level, then we would not need to replace potassium. But if we don't, then we would need to replace it. We're going to initiate their insulin therapy after we've initiated their saline boluses. And we will titrate based off of those hourly glucose levels. This is not the one and only HHS protocol out there. This is just an example of what a protocol might look like. Ultimately, you will default to your facility's DKA and HHS protocols. What you don't see in this protocol is the option to give sodium bicarbonate. That is only going to be in DKA. And you might not even see it that much in DKA because, again, it's the insulin that is going to correct that metabolic acidosis. And that is a wrap on diabetes and DKA and HHS. I hope this recording was helpful for you. If you have any questions, please jot them down so that we can cover them in our lecture on Thursday. Have a great night, great weekend, great week. Thanks, guys.